Hello everyone, I am Dr. Juma Bishwas. I am the mentor of RCOG Health. Today I will present one of the important topic in maternal medicine. This is not only important for part 2, that is also important for part 3 and as well as in part 1. So the name of the topic is acute fatty liver in pregnancy. Before discussing about this topic, I want to request you, please subscribe my channel and press the bell button so that you can get updated. Follow my Facebook page and Instagram. So let's assess yourself. There is a question in RCOG eLearning that's on call register. They take a call from a GP that there is a primary gravida at 36 weeks of gestation who has been vomiting for the last 4 days. So what will be the best course of action in that case? So the points are, ask the GP for prescribed antiemetics for the woman, ask the GP to refer the woman for endoscopy, ask the GP to refer the woman to gastroenterology, immediate assessment to rule out potential liver pathology, organize an immediate ultrasound of her liver. Can you guess the answer of this question? Okay, let's see. The answer is to immediate assessment to rule out the potential liver pathology. As because second trimester vomiting, especially irresistible, should be investigated to rule out potential liver pathology. You know that first trimester vomiting is quite common, but second trimester is very uncommon. So you have to take a good history clinical examination so that you can rule out other differential diagnoses of vomiting like reflux esophagitis, gastritis, and food poisoning. So let's start with the topic today, that is acute fatty liver in pregnancy. So it's quite rare but associated with multi-organ failure and has potentially fatal complication for both the mother and the baby if diagnosis is delayed. So it's a obstetric emergency. Though the incidence is very, very rare, like 1 in 7,000 to 1 in 20,000 pregnancies, and it is more common in first and multiple pregnancies, and there is a higher incidence associated with male fetuses, that is 3:1 ratio. So why this acute fatty liver happens? So the exact pathology of acute fatty liver in pregnancy is unknown. Women who develop the condition more likely to have a heterozygous long-chain 3-hydroxyacyl coenzyme, a dehydrogenase deficiency. In short, we can term it as an LC-HAD deficiency. 1,4-LC-HAD is involved in the beta oxidation of long-chain fatty acids, and this is a genetic mutation and it is inherited as an autosomal recessive condition. These are the symptoms and signs. So if patient present with nausea, vomiting, and malaise, this is the most commonest symptom. Right upper quadrant and epigastric pain, upper GIT hemorrhage, jaundice, headache, and pruritus. These are the signs. If you see a patient present with acute renal failure, hypoglycemia, infection, pancreatitis, and encephalopathy, so you may suspect the patient is suffer from acute fatty liver in pregnancy. And this is the Swansea criteria for diagnosis of acute fatty liver in pregnancy. If you see 6 or more of the following, in the absence of another explanation, then you have to think about acute fatty liver of pregnancy. These are vomiting, abdominal pain, polydipsia, polyuria, elevated bilirubin, hypoglycemia, raised urate, leukocytosis, ascites, elevated transaminase, renal impairment, elevated ammonia, microvesicular steatosis of liver biopsy. So if you see any patients present with vomiting, nausea, vomiting, that can be anything. So these are the differential diagnosis along with acute fatty liver in the pregnancy. So it can be HELLP, it can be severe preeclampsia, it can be hemolytic uremic syndrome or TTP, that is thrombotic thrombocytopenic purpura. So you can see, we can, in case of acute fatty liver of pregnancy, we may see hypertension, proteinuria, thrombocytopenia. Okay, so these are the things we will see. We will see high LDH, high bilirubin level, AST will be higher, and we will see fibrinogen will be higher, Antifibrinogen 3 will be less, and creatinine will be very, very high. Uric acid, there's no effect on uric acid. Glucose will be very low. So this is the investigations you can do, and this is the way you can differentiate from the other differential diagnosis. And this is histological changes in acute fatty liver of the pregnancy. You can see multiple fats in the liver tissues. So what will be the management plan in this case? So this is definitely an obstetric emergency. It's a very important thing. If you suspect, you have to promptly diagnose and treat the patient. And optimal management of acute fatty liver in pregnancy is prompt delivery and supportive care of the mother. So if any point, if you diagnose patient is suffering from acute fatty liver of the pregnancy, you have to think about delivery. MDT team input is extremely important. Close continuous monitoring after delivery is vital, as it can complicate severe PPH and multi-organ failure even after delivery. We have to aggressively correct the coagulation abnormalities. DIC, as because the DIC is the main severe and potential fetal complications of acute fatty liver of pregnancy. Hypoglycemia should be treated aggressively before and after delivery. In that case, we can give large amount of 50% IV glucose to correct hypoglycemia. If any point, if we see there is an PPH, we can do bedside massive transfusion. We can do ligation of internal iliac artery, and even if it is required, we can go for hysterectomy. Embolization procedure for uterine and internal iliac appear to be other possible treatment modalities in control of PPH. Overall recurrence risk is 15 to 25%. So if any woman have any history of acute fatty liver of the pregnancy, in that case, definitely they have a higher possibility. So you have to be cautious. Early recognition and appropriate referral from delivery and aggressive management, morbidity and mortality of acute fatty liver can be greatly reduced. A disease can cause rapid deterioration of both baby and mother. Early and prompt delivery can improve the neonatal outcome. Acute fatty liver is an obstetric emergency. Management is always based on a clinical rather than histological diagnosis. So if any point, if you suspect acute fatty liver of pregnancy, definitely have to treat. You can't wait for the histological diagnosis. So this is all about acute fatty liver in pregnancy. I hope you like this video. If you have any query, you can ask me on comment box. I will happy to answer all of your queries. And lastly, please subscribe my channel and press the bell icon. You can follow me on Facebook and Instagram. Thank you.